Um, the other group of drugs that have an effect on these parietal cells are the anti-muscarinic drugs. And so there are, of course, muscarinic receptors, and so these are M3 receptors that would normally bind to acetylcholine. Okay, and when bound, they activate this proton potassium ATPase, and they drive increases in calcium concentrations. All right, so atropine and glycopyrrolate will bind to these receptors and block this pathway. Okay, and then that'll indirectly block the activity then of that downstream potassium um, proton ATPase. Another drug that we can also consider is pyren, uh, pirenzepine, which is a M1 selective antagonist, and that will actually reduce gastric acid secretion. There will be no CNS effects with pyrenephrine. There will be, of course, CNS effects with atropine and glycopyrrolate. And so these are other reasons why these particular drugs are not the forefront of GERD treatment. And then another group of drugs are what are deemed cytoprotective drugs. And so Cytotec, or misoprostol, is basically an analog of prostaglandin E1. And so what you do is you put this drug in, and it basically stimulates prostaglandin receptors to produce more mucus, more bicarbonate, but less cyclic AMP. And so that less cyclic AMP feeds into that same pathway that we had talked about in terms of the parietal cells making more stomach acid. So if you, of course, if you reduce the amount of cyclic AMP, the outcome is going to be less stomach acid production. Okay, and so we use these cytoprotective agents in the context of ulcers that are NSAID induced. NSAID are non-steroidal anti-inflammatory drugs like ibuprofen. Not with, and we typically don't use misoprostol or Cytotec with ulcers that have different etiologies. Okay, so like a bacteria-induced ulcer would not be benefited particularly well by these agents. They have really short half-lives, so you would have to administer them 3 to 4 times a day. And the side effects produce a dose-dependent diarrhea, which is, of course, unpleasant. And, of course, we will talk about misoprostol and its prostaglandin effects in the life cycle component of the curriculum, but it basically is a hormonal type of effect. There are stimulatory effects on the uterus. Historically, this has been used as an abortion-inducing agent. So, of course, if a woman is pregnant and also has an ulcer, although I guess if she's pregnant, she wouldn't be taking high-dose NSAIDs anyway, but theoretically, she'd be contraindicated for this therapy as well. Other drugs that are cytoprotective include carafate or sucralfate, and this is more of like a polymer type compound. And so when it hits acidic conditions, as in like the GI system, this drug turns into a polymer, and it becomes kind of like a sticky gel, and it actually has a high degree of affinity for exposed protein, specifically the protein that are associated with the pathologies of these ulcers. Okay, and again, this gel is going to inhibit the diffusion of protons, and it's going to reduce the activity of pepsin. Usually this is administered on an empty stomach for obvious reasons, and before meals, up to 4 times a day. And so you can still use sucralfate for the prevention of stress-induced bleeding, and then it may also increase the risk of nosocomial pneumonia, like some of the other drugs in this category. There's very little to no absorption of this drug. It's a polymer. It's basically inert. There's some aluminum inside of this drug, and it may affect the kidneys at large doses, and it may actually impair the absorption of other drugs, as well as produce constipation. Okay, and so that's kind of the end of that category of drugs called cytoprotective agents. And so just as a review, the drugs that can control gastric acid include your H2 blockers, your proton pump inhibitors, the couple anti-muscarinic drugs, as well as the few cytoprotective agents that we had just talked about. So that sums it up for the first half of this lecture. Let's take a break and we will resume with the second half.